Hello everyone. Thank you for joining today's Web Interface Support webinar. The series of webinars is for accountable care organizations, ACOs, and groups that are reporting data for the quality performance category of the quality payment program through the CMS Web Interface for the 2018 performance period. These webinars will highlight important information and updates about reporting quality data and provide ACOs and groups with the opportunity to ask CMS subject matter experts their questions. During today's webinar, we will also share links to various resources and other information that will appear as announcements on your screen. Please note that these calls will only focus on reporting data for the quality performance category. We will not be covering reported data for the other performance categories during these calls. Now I will turn it over to Aruna Jasti from the Center for Medicare and Medicaid Innovation at CMS. Please go ahead.
Thank you. Good afternoon, everyone, and welcome to the CMS Web Interface Q&A session for the 2018 Quality Reporting for MIPS Groups and ACOs. I'm Aruna Jasti, and I'm part of the Next Generation ACO model at CMMI. Next slide, please. This is our disclaimer slide. So please contact the Quality Payment Program if you have any questions. Next slide, please. A quick announcement. The webinar materials from the last two sessions are now available on the Quality Payment Program webinar library. You can now access the recording and slides from the February 13th Web Interface Support Call and slides from the February 20th Web Interface Support Call. The recording from the last week's webinar will get posted to this page soon. Next slide, please. A few reminders. The web interface submission period will close promptly at 8 p.m. Eastern Daylight Time on Friday, March 22nd. And we would also like to remind you that your submission will be accepted automatically at the end of the submission period. Next slide, please. This slide provides information on when you should request for a CMS-approved reason. This option can be selected within the web interface only after the request is approved by CMS. Please be sure to submit your request as soon as possible. The requests sent after March 15th are unlikely to be processed prior to close of submission. Next slide, please. And this slide includes the steps you should follow to request a CMS-approved reason. You are required to submit one request per patient per measure. And please don't include any personally identifiable information or protected health information in the request. Next slide, please. And here are the dates for the upcoming CMS Web Interface webinars. We will have 3 more webinars in March before the web interface submission closes on March 22nd. The next webinar is on March 6th. Next slide, please. And now I'll turn this over to Angela Stevenson for the frequent measures question.
Hello, this is Angie Stevenson with the PIMS Measures team, and we're going to review some frequently asked questions we've received at the Quality Payment Program. First ones are regarding confirmation of the diagnosis for the PREV 13 statin therapy measure. Question 1 is, would the following terms qualify the patient for denominator inclusion for risk category 2 for the PREV 13 measure? Terms such as hyperlipidemia, dyslipidemia, and high cholesterol. The answer is no. These terms would not be considered confirmation of denominator eligibility for risk category 2 for the patients age 21 years and older. There must be medical record documentation that the patient was previously diagnosed with or currently has an active diagnosis of familial or pure hypercholesterolemia. A patient can also be included in the denominator for risk category 2 if they have ever had a documented fasting or direct laboratory test result of LDLC of 190 or greater. Question 2, what do we report if code E78.00 hypercholesterolemia is noted but without pure or familial? The coding in the 2018 PREP coding document is specific to familial or pure hypercholesterolemia, and it is considered to be all-inclusive. A description of hypercholesterolemia or the code of E78 alone is not sufficient documentation to confirm the diagnosis. In this case, where the description or documentation only states hypercholesterolemia, you would select no diagnosis and continue to risk category 3. The measure owner confirmed that the intent of this category and code is specific to pure hypercholesterolemia to identify the genetic component versus the broader term and interpretation of elevated or high cholesterol, which may be impacted by lifestyle. Next slide, please. Question 3 is, could you please clarify if we are able to use a SNOMED code to confirm the diagnosis for PREP 13 risk category 2? SNOMED codes are provided in the 2018 PREP coding document to assist you with finding an eligible diagnosis in the medical record, but coding alone is not acceptable. The medical record documentation must be reviewed and support whether the patient's hypercholesterolemia is pure or familial. Next slide, please. We have been receiving questions regarding when medical record documentation may be obtained or updated, and we've confirmed responses for those with CMS, and we'd like to share that information with you today. Question 1 is, can a MIPS group add documentation to the EMR in 2019 for payment year 2018? Or performance year, I'm sorry. For instance, if a colonoscopy is not found in the EMR during the data collection period for performance year 2018, and staff reached out to a performing facility to get a copy, and it is scanned into the EMR in 2019, can that be counted for performance year 2018? The answer is that QPP measures should be completed based on information available in the medical record prior to the end of the measurement period. There could be instances where the procedure encounter occurred toward the end of the measurement year, and the medical record was updated early in 2018. And I'm sorry, this should say 2019, I believe. But these instances should not be the norm. It would be more beneficial to the patient if coordination of care coincided with the patient's encounters as opposed to collecting missing information afterwards for the purposes of quality reporting. The submission period is not intended to be a time for filling in missing information, which was only identified due to the patient being attributed to the measure for performance purposes. The measures are not intended to interfere with clinical practices. If a measure calls for information that is not available, then the provider may not meet the intent of the measure. Next slide, please. This question is, are we allowed to go outside of the ACO participants to find medical record data? The answer is yes. CMS expects ACOs to make a concerted effort to obtain medical records for their assigned and sampled beneficiaries. This includes collaborating with physicians and or other clinic staff, both inside and outside the ACO, including but not limited to the NPIs provided in the CMS Web Interface, as well as facilities both inside and outside the ACO, with such collaboration attempts being repeated throughout the course of the data collection period if needed. Note that the data entered into the CMS Web Interface should never reflect services provided after the end of the performance year. for example, after 12/31/2018. Thank you, everyone. I'll turn it back over to Aruna. Thank you.
Thank you, Angela. The next few slides will provide information on all the resources that are available to you. Next slide, please. This slide includes a list of all the 2018 web interface resources available on the QPP Resource Library. Next slide, please. Please note the QPP Resource Library also includes links to the CMS Web Interface instructional videos. And this slide also provides a link to the QPP Help and Support page. Next slide, please. And as I mentioned earlier, the QPP webinar library includes webinar materials from all the previous web interface support calls. We will continue to post additional webinar materials as they become available. Next slide, please. And here are some additional resources for the Medicare Shared Savings Program and the Next Generation ACO model. Next slide, please. And if you need any assistance from the CMS team, please refer to the information listed on this slide. Next slide, please. Okay, now we'll have the Q&A session, and I'll turn this over to Michaela.
Great. Thank you, Aruna. So we are now going to start the Q&A portion of the webinar. You can ask questions via the chat or via phone. To ask a question via phone, please dial 1-866-452-7887, and if prompted, provide the conference ID number, which is 988-7417, and make sure to press *1 so that you're added to the question queue. And also, if you do have any follow-up questions or clarification that you'd like to share in the chat, please type follow-up question at the beginning of your chat question. That way we can keep an eye out for those. All right, so our first question comes from a group, and they're asking for measures like PREV 6 and PREV 5. Can we take verbiage pertaining to months or years? And so they're listing as an example, the patient had a colonoscopy 2 weeks ago that was normal, but could they say months or years? And then they say the same with mammogram. The patient had a mammogram 2 months ago.
Hi, this is Olga from the PINS team. You would need to have documentation indicating that the screenings are performed within a specified time frame as they're stated in the measure specifications. PREV 6 does specifically state that a year is needed for patient-reported. Mary, can you confirm if you can infer the year based on a statement of months that it would be acceptable?
Yeah, we would take that in on it if it said, it was done 2 weeks ago and, obviously can figure out what that year was.
Okay, great, thanks.
Great, thank you both. Our next question is on BMI. If a patient has an abnormal BMI and the provider documents under general counseling in the EMR that dietary counseling was given and exercise encouraged, would this count for follow-up for BMI?
So this is Deb. That would count for a recommended follow-up for an abnormal BMI as long as that recommendation was made on the date of the abnormal BMI where it was documented.
Thank you. And this next question is on PREV 7. If a patient has an office visit at the primary care provider during the influenza season, October through March, and the provider states that the patient is up to date with the flu shot, or the provider states patient already had a flu shot in 2017, does this count?
So this is Deb again, and there's actually going to be two different answers for this. When the provider is documented up to date during an office visit where we're talking about the relevant flu season, that up to date would mean that they received a flu vaccine for the flu season being measured. However, documenting already received a flu shot in 2017 would not indicate the same thing, as there are two different flu seasons that they could be referring to. And so there's no way to determine which flu vaccine was provided in 2017, whether it would be a vaccine that met the intent of the measure being documented or if it doesn't. Thank you.
Thank you. This next question is on the MH1 measure. If a patient was diagnosed with depression in 2017, then was an exclusion in 2018, and the measurement period was 2016 through 2017, would the exclusion fall in a different measurement period? How should we address this?
Hi, this is Jessica Schumacher from the PIMS measure team, and the measure specification and the measure owner set up guidance so that you can claim an exclusion if they have that diagnosis either during the denominator identification period to the last day of that measurement assessment period. So if that exclusion fell outside of the last day of the measurement assessment period, then you can't claim the exclusion. So I'm not quite sure if I'm following specifics of this scenario. So if there's more information, like if you want to submit the actual dates, so we can kind of map out that timeline and see what that patient is experiencing, we might be able to provide a more specific response. Otherwise, I hope that was helpful. Thank you.
Thank you. And Stephanie, do we have any questions on the phone?
We have a question from Jason Shropshire.
Hi, can you hear me?
Yes.
Hi, I just need some clarification on the CARE2 measure fall screening. So we have lots of cases where in the progress note, the provider will say will write patient is a falls risk, or provider gave precautions of falls risk. Does that count for the numerator or not?
Hi, this is Olga from the PIMS team. So as long as there's medical record documentation indicating any type of history of falls, if they're describing a fall, if they're saying no falls or gait or balance, then that would meet the intent of the measure.
But you're saying, so what I'm inferring from your response then, if they just say patient might be a falls risk, that will not count. That's what I need clarification on. If there's not a screening but falls were just obviously discussed and the provider thinks the patient might be a falls risk, does that or does that not meet the numerator?
This is Jessica from the measures team. So unfortunately, we're not able to interpret that provider's documentation either. Jason, would you be able to follow up with them for clarification on why they would have said that?
Okay, I mean, they're just going to say they discussed it with the patient, that they discussed falls. I'm just trying to determine from you if that would count for the numerator or not.
Sure. This is Deb, and the one thing I would bring in, because I think what we're saying is that the measure clearly states that there should be a false screen. I think what you're asking, Jason, is if in the event of an audit, and I'm assuming you're part of an ACO, if there's not documentation that a screening was done per se, but there's some indication that falls were discussed, or the provider has written that they feel that a patient might be at risk for falls, regardless of whether or not there was an assessment, would not be accepted in the event of an audit.
Exactly.
So I would say, Mary, this might be something that's best if you weigh in on, or if you want us to ask Jason to open up a quality net ticket, maybe we can do that.
No, Deb, I agree with you. Unless we see documentation about that they talked to the patient about falls, queried about falls, or they did a gait and balance assessment, it would not meet the numerator.
Okay, but you just said talk to the patient about falls. That's what I was asking.
Well, except I guess the example that you gave, patient is at risk for falls, I don't know what the physician is basing that statement on. Did they ask them about falls? Did they watch them walk? Did they see anything with gait and balance? I can't tell from the statement that you just gave me what the practitioner is basing his patient is at risk for falls, if it was on one of those two things or not.
Okay. All right. Thank you.
All right. Our next few questions are on IBD2. So the first asks, are patients who received DVT prophylaxis as inpatients, but not once they're discharged, excluded from the measure?
Hi, this is Olga from the PIMS team. If the patient received an anticoagulant at any time during the measurement year, then they can be excluded from the measure.
Thank you. And so this next IBD2 question is asking, what is the clinical rationale behind excluding those IBD patients who received a single dose of an anticoagulant?
Yep, and this is Olga again. So patients receiving anticoagulants are removed as a denominator exclusion in order to prevent physicians from getting penalized for using anticoagulants when they're actually clinically necessary. Antiplatelets are generally preferred over anticoagulants for the individuals who fall into this measure based on the feedback we received from the measure owner, but that is not always the case. Also, a patient might receive heparin and then later be put on an antiplatelet. A patient who happens to fall into the measure at the end of the year might only be on an anticoagulant and would otherwise count as a numerator fail without the exclusion in place. Although this, patients who receive anticoagulants, it's not an indication that they should never receive antiplatelets. It's just a less complicated way to specify the measure with the exclusion in place.
Great, thank you. And this next question asks, what happens if an organization reviews all 616 cases for IBD2 or MH1 and still ends up with a high skip rate greater than 10%?
This is Olivia. I think I can take that one if you come back to me in a few seconds.
Yeah, we can come back to that one. So our next question is on Prep 12. Why must a clinician document that a result of an age-appropriate, standardized, validated tool is positive or negative? And then they talk about how there is some research that indicates accepted, or they're asking when published research indicates accepted cutoffs for scoring.
This is Jessica Schumacher from the PIMS Measures team. And the instructions on the PHQ-9 state that the questionnaire relies on patient self-report. All responses should be verified by the clinician, and a definitive diagnosis is made on clinical grounds, taking into account how well the patient understood the questionnaire, as well as other relevant information that the provider might take into account from meeting with the patient during that encounter. Diagnoses of major depressive disorder or other depressive disorders also require impairment of social, occupational, or other important areas of functioning and ruling out normal bereavement. A history of a manic episode, such as bipolar disorder, and a physical disorder, medication, or other drugs as a biological cause of the depressive symptoms. So what that's saying is that the PHQ-9 is simply a tool that is being provided to providers so that they can have a guided discussion with their patient. However, based on psychiatric classifications as established in the Diagnostic Statistical Manual of Psychiatric Disorders, all those other elements need to be taken into account before a provider can say they have depression, they have major depression. There's other items that need to be taken into account. We strongly encourage groups to review the rationale section in the back of the measure. The 2019 Prev 12 measure spec continues to require that providers document positive and negative for depression. And if your group still disagrees with this, then you're more than welcome to submit comments during the next measure proposed, or the final, or measure, during the next Quality Payment Program rulemaking cycle, which will be happening this summer to prepare for the 2020 program year. If anyone has anything else to add, please feel free to jump in. Thank you.
Great. And Stephanie, do we have any questions on the phone at this time?
At this time, there are no questions. If you would like to ask a question, please press star, then the number 1 on your telephone keypad.
All right. So our next question asks, does a diagnosis of depression in remission count as an active diagnosis of depression?
This is Jessica again from the PIMS measures team, and I'm assuming this question's regarding MH1. So I encourage you to please reference the 2018 CMS Web Interface MH1 coding document, which is a spreadsheet included in the zipped file that contains the measure specs. And when you open up the spreadsheet, there'll be a tab at the bottom of the workbook called Denominator Codes, and that's a complete list of codes that are being pulled into the denominator. So if you have a diagnosis of depression in remission, I'm looking at it now. There are several different types of depression in remission that are included on that document, so please check that document, and if you have any questions or concerns, please contact the Service Center and we'll look into it. Thank you.
Thank you, and we're going to jump back to that question from earlier. So here's the question again. What happens if an organization reviews all 616 cases for IBD-2 or MH1 and still ends up with a high skip rate greater than 10%?
This is Olivia, so I can answer that question a bit from the shared savings program perspective. And basically, assuming you're kind of asking whether that would trigger your inclusion in the quality measures validation audit, not necessarily. We look holistically at the skip rates, and just at measure performance in general, kind of across the board to determine whether an ACO is selected for audits.
Great, thank you. And so our next question's on Prev 13. Can we use both LDLC and LDL to confirm the denominator inclusion for risk category 3? And they do note that page 6 of the measure spec specifies that we can use LDL or direct LDLC. And on page 13, under the risk category 3, it says LDLC only.
Hi, this is Angie from the PIMS measures team. The definition in the medical record, or in the measure specifications, does say that an LDLC result is required, and that it can be a fasting or direct LDLC test result documented in the medical record. Thank you.
Thank you. Our next question asks, does a documented follow-up plan that predates the most recent abnormal BMI meet the measure? For example, if the patient's most recent BMI on October 1st, 2018 is outside of the normal parameters and the follow-up plan occurred and was documented on March 23rd, earlier in 2018, would this meet the numerator?
So this would meet the numerator as long as the recommended follow-up is connected to an abnormal BMI. So they have to occur on the same encounter, and it's within the 12 months of the most recent encounter. So you can certainly, in your example, it is within that 12-month period of time, but that follow-up would have to be documented at the same time that there is documentation of an abnormal BMI. Thank you.
Thank you. Our next question is on PREV-12 depression screening. If a PHQ-9 score was done and the score was 3, but the provider does not interpret or comment on the screening, how should we complete our audit? Should we answer yes, that the patient had a depression screening, as it has a positive numerical result, even though it does not have a provider interpretation?
This is Jessica from the PIMS Measures team. So unfortunately, you wouldn't be able to count that screening if there is no interpretation. So you would code no that they did not have the screening. Thank you.
Thank you. And Stephanie, do we have any questions on the phone at this time?
We have a question from Brigitta Ober. Hi, this is Brigitta. Can you hear me?
Yes.
Okay. So as I'm uploading measures, I'm noting the numerator, denominator, and rate. And then when I upload subsequent measures, I'm noticing that the numerator and denominator are fluctuating with previously uploaded measures. Am I doing something wrong? Is that happening to other people? Does it have to do with beneficiaries counting for other measures? Or I don't even know where to begin to problem solve that. Hello?
Awesome. Is that something your team can address?
Hi. Sorry, we were trying to unmute the mute button. Could you repeat the question? Because we actually may have a question relative to your question, but can you repeat your question?
Sure. So I'm uploading measure by measure, so one measure at a time, and I'm noting what the numerator, denominator, and rate is when I upload a measure. So I've uploaded HTN, and then later I'll upload IVD, and I'll go back and I'll make sure I'll be looking at other measures, and HTN will have a different denominator and numerator, and then of course the rate will have changed. And I'm just wondering what I'm doing that is causing that to change.
There are a couple of things that might be happening if you are, let's say you have completed HTN, and then for another measure you have changed beneficiary data at the either demographic data, for example age is one example, or you have changed the beneficiary's confirmation for the sample. That might take, if that same beneficiary is also in HTN, that might take the beneficiary out of the sample, out of the minimum requirement count. That might be changing the counts that you're seeing for HTN. So it's hard to know without having the specifics. So if this did not answer your question, please open a help desk ticket with your detailed information and possibly screenshots of what you're seeing, so we can look at your specific organization data to identify if there's an issue.
Thank you.
All right, our next question is on PREV-12. If the screening questions are the same as the PHQ-2 and PHQ-9 questions, but the EMR displays the screening with the title of depression screening and not the name of the tool, will that count as a depression screen?
This is Jessica from the PIMS Measures team. So the name of the tool should be documented. You're right. However, if the questions used in the EMR are the exact same questions that are in the standardized PHQ-2 or the PHQ-9 screening tools or any other standardized depression screening tool, then it would be acceptable. However, in the event of an audit, if you don't have documentation of the name of the screening tool, then you would need to provide the questions just to confirm that they are the exact same questions that are provided in that standardized screening tool. It would be acceptable to provide a policy that indicates that PHQ-2 and or PHQ-9 tools that were incorporated into the EMR are the exact same. That would be acceptable. Thank you.
Thank you. Our next question asks, if we have a patient who has a malignant neoplasm of the gastrointestinal tract and brain metastasis, etc., can we skip them for Prep 6?
Hi, this is Olga from the PIMS team. There were a few questions regarding skips, and I just want to clarify that in order to request a CMS approved reason, you need to submit a ticket to the QPP Service Center. And so when you do so, please include the patient rank, the measure, and the reason for the request, and then a CMS decision will be provided in the resolution of the inquiry. We can't really answer that over the phone without additional information. Thank you.
Thank you. Our next question is on Care 1, medication reconciliation measures. We have records of discharge dates that differ from what is listed by CMS but are within a few days. There are also some that are off by a few months. How can we report for these patients when this occurs?
Hi, this is Katie from the PIMS team. So the measure requires that you must be able to verify the discharge date within 2 days. So for those, if you cannot verify the pre-populated discharge date, you should not confirm that patient. Thank you.
Thank you. This next question asks, on some of our quality measures, we have met and exceeded the minimum of 248 consecutively reported patients. Will you calculate an optimal score, the best score, based on all of the consecutive data we submit, or will you use all of the consecutive data?
Hi, this is Aslam. If you enter beneficiary data for more than 248 minimum required number of beneficiaries, all data you have entered will be included in the calculation of the score. Thank you.
Thank you. And Stephanie, we can take a phone question at this time.
Our next question is from Ann Finn.
Hi, I have Care 1 question. If a patient was transferred from one hospital to another for the same episode, would the MedRec from an ambulatory encounter within 30 days of discharge for the episode count for both hospital encounters?
So this is Deb. What you would want to look for, because you're not going to add any discharge dates to the web interface, so if you have 2 different discharge dates, one for each of those events, and then you have a documentation of the reconciliation post-discharge, and it meets that 30-day requirement of those, it could meet both of those pre-filled discharges. But you would want to look at what is populated in your web interface as far as your discharge dates, and then ensure that your follow-up within 30 days is, with the MedRec, is meeting both of those discharges.
So it's the same episode. So the patient, had chest pain, but then the patient preferred to be transferred to our hospital from another hospital. So I don't know. So basically, it would be, the medication, whatever that had been administered, would be transferred to our hospital. But so it's the same episode. So I'm not sure. And then on the Excel spreadsheet, it listed both of those dates, the one that was the date that the patient was transferred from the other hospital to ours. So I just want to make sure that I answered it correctly.
Right, and you would have. If both of those dates can be confirmed as discharge dates, that you have confirmation that both of those discharges occurred within 2 days, plus or minus 2 days of the discharge that you've been provided, and you find a MedRec that was completed and that MedRec happened to be within 30 days of both of those discharges, then you can use that MedRec for both of them.
Oh, okay. Thank you so much. And would that same rule apply to internal transfer from one facility to another within one same organization?
So that would apply to any of the Care 1s. If you've confirmed, so when CMS provides a discharge date and you confirm that discharge date, you very well may have more than one discharge date within a short period of time. And if you have a MedRec that occurs within 30 days of those discharge dates that have been pre-filled, then that MedRec can apply to both as long as it meets the parameters of the medication reconciliation in the measure.
Okay, and I have one last question if that's okay. If not, then I can wait for another opportunity to ask. Hello?
I think it would be fine, but as long as the moderator's okay, I say go ahead and ask.
So just one more question. If a patient has aspirin allergy, then I would count that as not meeting the numerator, correct?
Which measure? I'm assuming you're referring to the IVD measure?
Correct.
And that's correct. Having an allergy to an aspirin is not a denominator exception or exclusion for that particular measure. If, however, you find through your medical record documentation and what you're finding that there's other things going on and this is a scenario you want CMS to review and potentially give you a skip, then you would follow what Olga provided earlier and request that skip and see if there's enough detail for that particular patient to have them skipped. But simply having an allergy to aspirin because there's other medications that can be provided is not enough to remove that patient from the measure.
Thank you, ma'am.
Thank you.
Thank you. Our next question asks, for IBD, can you please clarify, and they're asking about if a patient received multiple injections of a heparin flush during a hospital stay, then the patient would be excluded from the measure as this is more than a brief use, correct?
Hi, this is Olga. No, they would not be excluded. And the reasoning for this is a heparin flush is used to flush out the IV catheter, which helps prevent any blockage in that tube. Typically, the heparin flush is a much smaller dosage than anyone that would be prescribed actual heparin. So the heparin flush itself, it's not used to treat or prevent the blood clots in the body, and it does not meet the definition of an anticoagulant. Only heparin or another anticoagulant that is prescribed to the patient for the actual purpose of treating or preventing blood clots would be considered an exclusion.
Thank you. And this next question's on Prev 13. If the diagnosis code E7800 or E7801 is documented in the patient's chart with the diagnosis pure or familial hypercholesterolemia, is this sufficient? And if not, what else is required to support the diagnosis?
Hi, this is Angie with PIMS. If it is included in the diagnosis code description, either on the patient's problem list, on the encounter, or documented in the progress note that the patient's being actively treated for the hypercholesterolemia and it supports pure or familiar, it's acceptable. Thank you.
Thank you. And this next question asks, on Prev 9 BMI, if a patient's last recorded abnormal BMI was in December 2018 with no plan documented, but we have documentation of an abnormal BMI with a plan in January of 2018, does that meet the measure because it's within the measurement year?
So this is Deb again, and just to again kind of explain how that look back for the BMI works. If your most recent abnormal BMI that you have documented does not include a recommended follow-up, you are able to look back in that look back period, so you can look back 12 months for another documented abnormal BMI with a recommended follow-up. So please note, within the measure specification, if you kind of follow that workflow, and I know some of that language may seem to cause some confusion, but the basic thing is to look at your most recent visit, find within that 12-month period if you have an abnormal BMI documented. If you have an abnormal BMI documented, look for a recommended follow-up. If you do not find a recommended follow-up, you do have that 12-month look-back period from the most recent encounter. And if you find another abnormal BMI within that look-back period and it does have a recommended follow-up, you can use that. Thank you.
Thank you. And Stephanie, do we have any phone questions at this time?
There are no questions at this time. If you would like to ask a question, press star then the number 1.
Thank you. Our next question is on Prep 10. If a patient was screened for tobacco and was positive, and the physician includes in their note that they discussed tobacco use with the patient, would that count?
Hi, this is Angie. The measure specifications do say that tobacco cessation intervention includes brief counseling of 3 minutes or less. I am not sure of the exact note in this record that you're speaking of, but it seems that it may be able to be assumed that tobacco use being discussed may meet the definition of counseling. I was wondering if ACO PAC team could comment on that, or if we'd prefer that you submit a case to the Quality Payment Program with the details.
Why don't we go ahead and have them submit a case with details, because it's hard to tell from that exactly what that note says.
Alrighty, thank you, I agree. Thanks for the question.
All right, our next question is on Care 2, falls risk. Is a gait assessment such as patient has normal gait sufficient to meet the criteria?
Hi, this is Olga with the PIM teams. Yes, as long as gait within normal limits, gait steady, or gait unsteady is documented during the measurement year, it would be considered fall screening.
Thank you. Our next question asks, let's see, it's on Prep 12. It says the measure does not say that you are determining whether the patient has major depression, but it states that you must indicate if a positive or negative for depression. And in addition, the provider may indicate positive for depression, but may not code for any type of depression at that time, but may state a follow-up plan. Does any type of coding need to be associated with that determination of positive for depression?
So no, you don't need any coding if the provider indicates depression in response to a screening. And I apologize if that was confusing. I just referenced the instructions of the PHQ-9 to help explain kind of the purpose of the tool, in that it's just to guide conversation to help the provider identify any issues the patient might be having. And just to emphasize that there are so many other factors that need to be taken into account, which is why the provider's interpretation is so important. So for example, if there's a patient who has a PHQ-9 score of 0, so the provider enters, or the nurse or whoever administers the tool, the EMR is populated with a 0. During the exam, the provider might notice cut marks, which would be indicative of suicidality, or in conversation, the patient might express hopelessness, loss of interest, symptoms that were on the screening that they denied. It's very easy for self-reports to deny symptoms because they think they are doing fine. So if there's notation that the provider thinks that their patient has depression or not, that really is the key for this measure, is is, does this patient, were they screened? Do they express depression? If there was any, then what is the follow-up? So for Prev 12, if the provider indicates, they have a score of 5 and they express depression, so the follow-up is to send them to a psychiatric provider for a more thorough detail, then that would meet the intent of the measure. Thank you.
Great, thank you. And Stephanie, do we have any phone questions?
We do have a question from Vishon Khan. Vishon, go ahead with your question. Vishon, do you have a question?
Hello, can you hear me?
Yes.
Go ahead.
Sorry about that. Okay. Yes, I had a question regarding MH1. For MH1, we're seeing approximately about 70% of our patients that we've audited so far coming back as skipped because their first PHQ-9 is coming back not greater than 9. So my question is, do we have to go all the way to the end of the ranks, or is there a threshold for that? Because I know for this measure, for us, it's reporting only.
This is Jessica from the measures team. I can start out, but if others from sampling want to jump in, you're more than welcome to. So correct, you would need to go through your complete list of beneficiaries in ranked order. You need to report on the full beneficiary load in order, and see, there's actually a FAQ in the Q&A document that speaks to this. CMS is aware that groups might have a high skip rate for MH1, but just continue through your patient load and report as best as you can. Thank you.
Great. Thank you. What was the documentation that you said I could find that at?
Oh, absolutely. Are you on the webinar?
Yes.
Okay, we'll go ahead and we'll push it. We have 6 minutes left, so we'll push it. There's like a pop-up box that has links, so we'll push it so you have the link right now. Otherwise, for those of you who aren't on the webinar and don't want to look at that box, please go to the Quality Payment Program website, which is qpp.cms.gov. And in the upper right-hand corner, you're going to click on About. And in that drop-down, there's a link called the Resource Library. And you're going to kind of scroll down towards the bottom of the page. All the resources are listed in one long list. If you want to find it quickly in the search box, you would just type in, I believe it's FAQ. And if I push enter, nothing comes up. I'm sorry. So web interface. And all the web interface resources will pull up. And in there you're going to find a document called the 2018 CMS Web Interface FAQs, which is frequently asked questions. And I am going to, real quick, do a search. And you're going to look for, on page 15, it's frequent question number 8. Large number of skips. MH1 requires PHQ-9 to be confirmed. If your group doesn't do it or if you have large skips, replaces beneficiaries with others until 248 records are consecutively confirmed and completed, or until you have exhausted your sample. So I'll get that link added to the webinar right now. Thank you.
Thank you.
Thank you. And our next question is a follow-up on Prev 7. Did you say that up-to-date is acceptable when in the current flu season?
So this is Deb. Yeah, that's what I said. And basically that's because if you have a visit between October 1st and March 31st and you're saying that the flu shot is up to date, it can be inferred that that flu shot is for the current flu season. Otherwise, it would not be considered up to date. Mary, I don't know if you have anything you want to add to that or if you feel that that is inaccurate, but I think this kind of is the same type of scenario as we discussed earlier in the call with Prev 5 and Prev 6.
Yeah, I agree.
Okay, thank you.
Thank you. Our next question is on Prev 9 BMI, which should be reviewed first. A patient refusal of weight and height or a qualifying BMI screening completed. And they note that they have patients who may have had a qualifying BMI, height, and weight calculated, but also who refuse measurement during the year.
And this is Deb. For denominator exclusions, the one thing you want to make sure that you do, denominator exclusions are patients that are not intended to be part of the measure. Therefore, if you are finding a denominator exclusion, you should exclude them up front. So if you have documentation that a patient refused the BMI, they should be removed. The denominator exceptions work a little bit different, but for the BMI measure, the denominator exceptions do not include patient refusal. So in this particular measure and in the scenario that you provided, the patient should be removed as a denominator exclusion. Thank you.
Thank you. This next question's on Care 2. What if a patient had a fall and came to the clinic for a fall follow-up? Would that fall follow-up be considered as meeting the measure because the patient apparently has had a history of falls?
Hi, it's Olga from the PIMS team. Yes, a patient's history of falls within the medical record would meet the intent of the measure.
Thank you, and we have time for one more question. So this last question asks, if you do not have a coordinated chart, are you required to pull claims to find the last visit from other providers for certain measures, or are you responsible to abstract from information that is in the chart you are abstracting from?
Hi, Michaela. Can you just repeat the question again?
Yeah, it asks, if you do not have a coordinated chart, are you required to pull claims to find the last visit from other providers for certain measures, or are you responsible to abstract from information that is in the chart that you're abstracting from?
Would someone from your team or Deb
Sure.
be able to answer that question? Because this is a follow-up from last week.
Sure, this is Jessica Schumacher from the PIMS Measures team. So the intent of the web interface reporting is that the data should be available within the medical record documentation so that it is available to the clinical care team and also available in the event of an audit. There are some specific scenarios where you would be able to reference billing, but it would only be under certain scenarios, and I'm trying to think of them now. If others have anything they want to add on, please feel free to jump on.
I guess I would just add, if this didn't answer the caller's question, it would be best if you submit a QualityNet help desk ticket because it may require a couple of different groups to be able to provide you an answer. If it did answer your question, as I know Jess does a great job with that, then please ignore the recommendation. But if we didn't answer, please open up a QualityNet help desk ticket.
Great. Well, thank you, everyone. That is all the time that we have for today. Next slide, please. And if we weren't able to answer your question, please do feel free to email those email addresses for help with the Quality Payment Program, the Medicare Shared Savings Program, and Next Generation. We did send those out as an announcement earlier. And if we can go to the next slide, here they are again. And we also encourage you to join us for our next webinar on March 6th. Thank you.
Thank you. This concludes today's conference. You may now disconnect. Speakers, please hold the line.